Depuis maintenant près de 4 ans, ma vie a pris un réel sens. J'ai trouvé une façon de me rendre utile. J'ai trouvé le moyen de partager mes talents. J'ai trouvé comment aider à ma manière. À cette question qu'on me demande souvent, pourquoi tu fais ce que tu fais? Je le fais parce que j'aime ce que j'ai créé. J'adore les femmes que j'accompagne, je les supporte, je les écoute et je les défends avec cœur. À chaque mission, je me répète que j'ai de la chance d'avoir retrouvé la femme que je suis et de laisser une petite trace dans la vie d'autant de femmes. Je m'appelle Cynthia Gagné et plusieurs fois par année, j'accompagne des femmes vers le docteur Veronikis, un expert mondial en retraite bandelettes pour incontinence urinaire et d'implants pour prolapsus. C'est ici, dans mon salon, qu'elles me partagent leur histoire. Donc, aujourd'hui, j'ai un invité spécial avec nous. J'ai le docteur Veronikis qui accepte de prendre un petit moment sur le divan de la Maison des Améchés. Merci, Dr. Veronikis. Thank you very much. So, are you agree if we do the interview in French?
Sure.
Yes.
Sure.
Did you learn some word in French since all this story with Améché?
Un peu.
Un peu? Okay. Good. I think it's better if I talk in English with you.
I think so too.
Okay. Good. Thank you to take the time with me and be open about how what we live with Améché. So, I want to ask you, this group is very, very special for me because it was the first time I helped women from British Columbia, from Australia. I helped women from France since maybe 1 year, but they had big surgery. So it was a very big week. We have women from Quebec. And I'm not sure, but I think it was a big week for you. I think you told me that it was the biggest week you never had. So you did. We did, but you did 9 surgery. So what you learn about that group, the group 26, what you learn about the surgery, what you have to tell me about that group?
Well, it's a very diverse group, not only in culture, France, Canada, but British Columbia, Canada, which speaks English.
Yes.
Quebec, Canada, which speaks French, although it's Canada, that's different cultures.
Yes.
Quebec population speaks French. The French population speaks French, but it's a different French.
Yes.
It's a different culture. Then you had the diversity of the cultures with the diversity of the meshes.
Yes.
You had retropubic slings, transobturator slings, slings that are called single incision slings with anchors. Woman that had 2 slings. Patients that have what's called a promentofixation, some that have the uterus in place, some that have the cervix in place, some that have mesh exposed in the vagina, mesh erosion in the bladder, close to the kidney tube, mesh around the uterus with a transobturator sling.
Yes.
So it was 1 full week completely full of mesh removals, where when it's a sling, the kit identifies the type of mesh, the location of the mesh. Although there's variations in the pelvis, and there's variations in surgical technique by different surgeons, you have an understanding of where to expect to dissect and find the mesh.
Yes.
When it comes to promentofixations, that's more of a surgeon-dependent technique.
So it's very unique, like what we saw this week.
I've never experienced anything like
No.
this.
Even in US, it's like sacrocolpopexy, but promotofixation is it the same? But
Same thing.
same.
The promontory is a location on the sacrum where disc 1 is located and the pelvis attaches to the sacrum. In the United States, English-speaking languages, they call it sacrocolpopexy.
Is the same thing?
Same attachment point near the sacrum.
Okay.
The location varies.
But what you see, you saw different about that week and about what you saw with that 3 girls. I want to know because...
So those 3 surgeries in particular, which were back to back to back.
Yes.
1 on one day and then 2 the following day. There were similarities yet differences. The similarities are that it was along the right pelvic sidewall where the ureter and the iliac vein is, which is an extremely dangerous dissection that follows the course of the ureter to attach to the uterus or to the cervix. Two of the patients had a uterus.
I know the answer, but I want to ask for the people, they listen you, they watch us. Do you use laparoscopy? Do you use cilioscopy?
No.
I know the answer, but
all 3 had it placed laparoscopically, minimally invasively, but...
But you...
No.
You never use that?
No, I don't use laparoscopy because it's not the same surgery. It can be done minimally invasively, but in my hands, it's not the same surgery. And I must tell you that all of the patients that have problems with sacrocolpopexy or promontofixation invariably have it placed through a laparoscopic approach.
Okay.
And invariably, the mesh is off the midline because the bowel is in the midline and the bowel needs to be moved to attach the mesh onto the promontory or the sacrum.
Okay. Can I ask you something and maybe you can explain what is laparoscopy, but in simple word?
Sure.
Okay,
sure.
just very simple, because we know that word, but women don't know. They say, "Oh, it's a robot. It's nice. It's new. It's the best thing." But you know, I just want something simple that the woman can understand. What is the laparoscopy or cilioscopy in French?
Sure. So let me start by saying abdominal surgeries, you make an incision.
Yes.
And you see directly with your eyes.
Yes.
In laparoscopy,
yes,
you make a small incision and you put a camera, usually in the belly button.
Okay.
And you put 2 little ports, 2 little incisions, and you use long instruments with graspers to do surgery.
So they put hair inside?
Typically it's carbon dioxide.
Okay.
Okay. And that's laparoscopy. The invention of, you said earlier, robot,
yes,
it's still laparoscopy, but the way to think of it is that robotic laparoscopy uses an interface of a computer to manipulate the arms.
Okay, so my question is maybe weird, but you know, I'm just a simple woman, so they use a computer and they do that like that, and they look at the computer in a camera, you know, understand my
Yes, so the camera shows the anatomy,
yes,
whether it's conventional laparoscopy,
okay,
and the camera looks at the anatomy. If it's robotic surgery, through the interface of a computer where the surgeon sits at a console.
A console like a play, like a Nintendo or PlayStation?
It's not exactly like that.
No, but you know, I'm sure that I am not the only that ask that question.
Sure. So the surgeon sits at a console, which has foot pedals,
okay,
and hand maneuvers that manipulates the arms. In conventional laparoscopy, the surgeon is next to the patient.
Okay.
In robotic surgery, there are people next to the patient, but the surgeon sits at a console.
Okay. So you must be very good with that computer?
It's not the computer. It's hand motions are affected or transmitted by a computer to the arms that are attached to the patient.
Okay.
So there's a steep learning curve to do that, and you don't have the same what we call haptic feedback.
Well, what is the meaning
So
of that word?
when you do surgery, if you
Yes.
take an instrument and you touch tissue,
Yes.
the tissue gives you a sensation back.
Okay. Yeah. Okay.
Okay? With laparoscopy, the surgeon retains that feeling of
Okay.
tissue.
Okay.
Tendon, bone, bladder, blood vessel, ureter. With the robotic approach, you do not have that feedback.
Okay. So you use your finger to touch, to feel your eyes.
No,
No,
you use
no, for
your-
you.
Oh, when I
your
do
technique.
surgery?
Yes, because you don't use that laparoscopic
I don't
surgery.
do laparoscopy.
You
I
only
don't do
like
robotics.
your eyes, your finger, your
Yes,
instrument.
I use all my senses.
Okay, all your sense.
All my
What I wanted.
senses.
Okay,
And there's no replacement for the human hand and the human sensation.
only your hand.
Yes,
Okay, why?
that's what I do.
Okay. Did you try in the past?
I tried robotics in the past.
Okay.
I've been doing this 30 years.
30 years.
30 years. When the robot became available,
Mm-hmm.
the hospital asked me to participate. So in 2003, I did a sacrocolpopexy
With that robot.
with the robot
Okay,
in 2003. Prior to that, I had done...
20 years ago.
Yes.
Okay.
Prior to that, I had done hundreds, maybe 1,000 open surgeries.
Okay.
Okay? And it was not the same. So as a surgeon, you think, well, maybe it's okay this way, but I know my results, I know my outcomes. Changing the modality of surgery should not change the operation.
Mm-hmm.
So I wanted to do the same operation that I did with an incision, but to do it less invasively. I realized that after 3 surgeries, that was not possible, so I stopped. Okay? And I mainly do vaginal surgery and open surgery. And then in 2011, they asked me again to reconsider it. I did. I did a number of surgeries. And again, I saw that the results are not the same as I was doing open. For me, for my results, the way I want my surgery to be, the outcomes I want, the length of repairs from the apex, how well I fixed the prolapse, I had a benchmark of outcomes and complications.
Okay.
And I wanted that same benchmark. If I change the way that I create exposure, I want the same result.
Okay.
I was not able to achieve that. At the same time, being a surgeon of last resort, I started to see complications with patients that had undergone sacrocolpopexy prominental fixation with a less invasive technique, meaning no incision,
Yes.
laparoscopically, cilioscopy, same thing, or robotically. So I inherently knew that my judgment was accurate, that it's not the same surgery. The prolapse can be fixed, maybe, not as good, and I confirmed that the 3 patients that I saw, they had a prominental fixation,
Yes.
and all 3 of them had prolapse.
Okay. So it doesn't work?
Well, it does work sometimes, but it doesn't work the same for me the way that I did it open.
Okay.
And almost every single prominental fixation, sacrocolpopexy that I have had to remove is because it was done laparoscopically or robotically. So I don't think it's a good approach.
You think you need your touch? The touch?
Nothing replaces the surgeon's sensation. Nothing.
Nothing.
Nothing. The technology says, 7 degrees of freedom, the hand moves, the instruments move the same way, but it's not the same.
Mm-hmm.
Nothing can compare to the surgeon's hand.
I totally agree with you. So I must to ask you, what do you think of that kind of surgery
So
that we saw that week?
it was not good. It was not all 3 of those patients did not have good results. The one patient had exposure in the vagina with several repairs. still had mesh exposure, still had pain, still had prolapse. The other patient had a promental fixation with mesh in the bladder, had the calculus removed off the mesh, still had mesh in the bladder, predisposing to constant pain, urinary tract infections, and still had prolapse. The other patient had continued prolapse with the uterus and a transobturator sling, and you cannot do a repair around the mesh.
No.
You cannot do an elevation when the mesh is in the way. So you almost have to go back to the beginning of normal anatomy to be able to take a conventional operation and redo it. You can't have an operation that works one way and try to do another operation. And certainly you can't put mesh on top of mesh, and I'm not saying anyone should do that, but someone might try to do that. It's not going to work.
Can I ask you a question? And the last question?
Sure.
Do you use mesh, you?
No.
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 Zero.
Zero.
So it's possible to repair prolapse without mesh?
Oh, absolutely.
Absolutely. And you don't use mesh, kit mesh and all of that?
I never used the mesh kit.
You never used mesh kit?
Never used the mesh kit.
You know how is it? You know, I am on a lot of Facebook groups, so I saw often something about you used in the past mesh. I want to ask you, you used mesh before?
I did.
Yes? Okay.
I did. I didn't use mesh kits.
Mesh kits means?
ProLift.
Okay. So in a box?
Not in the box.
Okay.
I was trained to use mesh.
Like all the other surgeons.
And I had my own technique. I always looked at my outcomes, always looked at my complications, never wanted to hurt a patient. But above all, I never did anything that I couldn't fix. Okay. And I'm a responsible surgeon. If something is not right, I will take care of it. I'm responsible, I will take care of it. So I did biologic slings in the past. So when mesh became available for slings, I took that same operation that I was doing without mesh and used mesh. I had my own instruments that I designed to do the sling placement. So as I mentioned earlier, I didn't want to change the operation because I had a robot or laparoscopy. I take my conventional operation that I know the complications, I know the outcomes, and I change one thing.
Okay.
Patients did okay with the mesh.
Okay.
But I see what it has done, so I have stopped using it completely. And honestly, my results are the same when I use biologic materials and sutures than when I use mesh.
Why they don't use that biologic tissue, or why they keep going to use that? Why they still use that mesh and they put mesh in women? Training,
it's what they know how to do.
Okay.
It's what they...
Is it the same? Is it easy like mesh?
It's easy.
It's easy?
Yep, it's easy.
For you?
For me, it's easy.
For you, it's easy. Okay. Thank you for your honesty. Thank you to be with us.
Thank you for inviting me, for having me here. Thank you.
Thank you. And I wish they will stop to use that mesh. I wish.
I'm not sure that will happen anytime soon, but...
No? We can have a dream.
Yes,
For the
absolutely.
moment. Thank you, Dr. Veronikis.
You're welcome.
Thank you.
Thank you.
Merci d'avoir été présent. Merci à mes invités d'avoir partagé leur expérience. Suivez-moi sur ma page Facebook, l'Expérience à Mécher, et mettez vos commentaires sur la vidéo. Un gros merci. Bye!